Now, I want to expand this conversation about diabetic ulcers to include Dr. Lorenzo Patrone, our 2020 Global Vascular Specialist of the Year, because he has a panel of physicians standing by to discuss the critical team effort it takes by multiple doctors to properly treat PAD and help patients to live a better quality of life. Dr. Lorenzo Patrone.
Hello, hi. So it's a pleasure for me to be here. Thank you, Kim, for the invitation. And actually, today I'm here with a very special team of friends, colleagues, and very good experts. We have Dr. Isa from Spain, and you can see that he's just his background is in hospital, so he's on call. And actually, we're very lucky to have him here. He was a fantastic vascular surgeon. He's a fantastic technique and very sensitive person. And Dr. Alexander Wee, who's instead is an orthopedic surgeon from Frimley Park, which is in Surrey, very close to London. And we are going to try to coordinate this session where we're going to try to explain what we can do for people with diabetes. And we're going to try to understand, as you know, it was nice to hear, you know, of Stacia before, the podiatrist, to understand who sometimes can be saved, who cannot, and what can you do for people to try to give them the best quality of life possible. Especially, you know, in particular, I'm very proud that Mr. Wee is with us because he's orthopedic surgeon, he's a foot surgeon, and he's going to explain us how you can minimize, even in cases of advanced osteomyelitis or sepsis, the amount of amputation. So, August, are you online?
Yep, thank you. How are you? So thank you very much, Lorenzo, for your kind introduction. Slightly overwhelmed about it. It's really a pleasure to be part of this panel. I'm having some issue with my internet connection, so if you feel that my connection is strong enough, we can just switch to Alex, and I will try to get back with another user called Challenge GTI. Is it right?
Yeah. I mean, I can see, okay. I can hear you very well.
Okay, excellent. So I'm gonna share my screen if I'm able. Okay. Okay, here we are. So you asked me to present two cases, and this is going to be the first one. She's an 87-year-old lady with high blood pressure, diabetes mellitus, dyslipidemia. She has a coronary arterial disease with 2 prior PCIs, COPD as well. And the chief complaint was an extensive necrotic ulcer on the left heel and also on the posterior aspect of the calf, where the Achilles tendon was actually exposed. So physical examination revealed that she had no pulses below the left groin. A white blood cell count was not actually too raised to increase. ABI were not compressible as usual with diabetic guys. And the TCPO2 was low, with 18 millimeters of mercury. So we decided to take her in the OR, and we performed an angio, which revealed a disease, SFA, with an occlusion at the level of the adductor canal and a reconstitution at the P2 segment. And below the knee, the vessels were also diseased, anterior tibial artery, and probably dorsalis pedis artery at the level of the foot. So we decided to try to recanalize antegrade the SFA occlusion, but unfortunately we failed, and we needed to switch immediately to the retrograde puncture in the DP artery, and we managed to recanalize the whole artery, and thereafter we performed an angioplasty of the anterior tibial artery. So we also performed an extensive debridement of the ulcers, and intra-op swabs were positive for Staph aureus and Citrobacter, and we put her on cotrimoxazole. And following the debridement, we put her on negative wound pressure therapy. And she stayed with us 7 days. And when she was discharged, she had distal pulse at the DP artery, and the TCPO2 has increased up to 62 millimeters of mercury. So she was discharged with home care assistance. And initially, the wound at the level of the posterior aspect of the calf, as you can see, was pretty nice with granulation tissue, but unfortunately, the wound at the level of the heel was not doing so well, what we call an orphan heel. So that's why we decided to bring her again in to perform another angio. And this is the angio, what we assess a patency of the former revascularization procedure with inline flow at the level of the anterior tibial and even in the DP artery with a piece of plantar arch. But as you can see, the rear foot was absolutely without any sort of perfusion. So that's why we decided to go for the posterior tibial artery in order to increase the flow there. But unfortunately, we ended up in a perforation. And when that happens, to save this situation, we perform some wiring maneuvers, think about a retrograde puncture or a subintimal dissection. And we did the latest. But again, when we arrived to the plantar artery bifurcation, we could not re-enter into the true lumen. At that stage, we can think about performing a CDO wire maneuvers, an extreme retrograde puncture or a plantar loop. And then you need to perform the rendezvous with card, reverse card, double balloon, even the repop technique described by you using an outback and a balloon or a Vascular technique. So we decided to go for the DP to perform a plantar loop, but then we suddenly realized that the arch was actually diseased, severely diseased, and eventually we end up in a perforation. So at that stage, we decided to perform a direct puncture of the plantar arch. This is our 21 gauge needle and the wire getting into the digital artery, into the metatarsal. So we perform an angio, trying to see where was the lateral plantar. And then we retrieve the wire and redirect this wire into the lateral plantar artery. So here we are. This is the check angio. And this is a nice picture to show you the relevance of the multi-level approach when you're dealing with complex cases. So in this lateral view, we perform a dual angio from the sheath and the support catheter. And we just needed to cross the occlusion of the plantar artery. So we drill our wire, change the direction of the wire, and steer it to the wire on the posterior tibial artery. And we eventually did it. And we performed the rendezvous in the popliteal artery within the Bernstein 2 catheter. So we perform an angioplasty of the posterior tibial, the lateral plantar, and the plantar arch. And this is the final result with two vessels going down even the arch.
Doctor, I don't mean to derail your amazing presentation, but I want everyone to really take notice because you're showing amazing visuals where our friends with PAD can actually see how you are going into the foot. And here in hospitals, most hospitals will not do it. They think it's radical. They tell our friends with PAD that their vessels are too small below the knee and the tibials, let alone down there into the plantar loop. Why is it that hospital doctors over in the UK are skilled in doing this and do it seemingly with ease, but here in the US, it's not something that's standard? And maybe I think Dr. Ashish Gupta and Dr. Paul Michael are here who also do it, but they're in office-based labs. Maybe they want to weigh in as well, but I'm curious, Doctor, what you think first. I mean, this is amazing.
Well, I don't think that I have the right answer, to be honest. I think it has to do with training. We all were trained in these techniques by probably what we call the Italian squadra, which from Mansi, Ferretti, all of these chaps. You have access to all of this training with workshops. We visualize clips. I've learned quite a lot from Lorenzo, of course. So it's an issue of learning and try to start with simple cases and then increasing the difficulty of the cases.
That's amazing.
August actually is incredibly humble. It's incredibly humble. He learns from me, but I learn from him a lot. So essentially, it's also good to have a group also on the web, and we share cases, we share techniques, we share failures, we share everything, because it's important not to, you know, live in a fake world where everything works, everything is perfect. You know, these kind of interventions are fantastic, and you know, I can imagine how happy was August when he passed the wire through this kind of plantar artery occlusions. But it's to reach that point, that sensitivity in feeling the wire, it takes a long time. And actually, he's in Spain, I'm in UK, there are other different people, and we try also our best to create workshops. He does workshops, I try to do my workshops, and we try to, you know, engage with people. And actually, it's very nice to do workshops because you learn yourself from other people, but also to try to push also the mentality of nothing is really impossible until you try once or twice or even 3 times. Then you can say, okay, I tried hard and I can't do. But to say the vessels in below the knee are too small, no, it doesn't fit. I mean, the foot arch is something that is reserved for particular cases. So I think that, I mean, then I will ask August also, Dr. Isa, what he thinks, but not more than 20% of my BTK work is around the foot arch, because the foot arch is sometimes, as we see in other cases, is patent, sometimes is enough to revascularize one vessel. And so it's not like just to go around the loop. Sometimes people do it, they overdo and then destroy everything. It's far worse than before. So you always have to have, I think, and I will ask you, August, what you think, the sensitivity and experience to see, okay, this time is needed, this time is not. What do you think?
Yeah, definitely. I completely agree with you. It's not only your opinion. The guys who invented the technique, even Manfredi Cacciani, described the usage of the plantar loop in 20–30% of the cases, because this is quite elegant, but if you fail, this is a complete disaster. You need to amputate the guy. So you need to be extremely cautious with the indication. I don't think that it should be on your mind at the beginning of the procedure. Definitely, if you need to do it, let's do it. But if you achieve perfusion on the wound, probably that's enough, direct or indirect perfusion.
And Paul, are you online? Paul Michael, my friend from Florida. Yeah. Okay, what do you think? Hi, Paul.
Oh no, I think he might have just jumped off. But we also have Dr. Ashish Gupta, who's also just down the street from him in a sense, in Florida, who could probably weigh in. He's also going to be presenting some of his cases very soon.
Okay, shall I carry on?
Yes, I would. We would just love you to weigh in on that.
Excellent. So the clinical course of the lady was pretty fine. We achieved negative wound cultures, granulation tissue, and we carry on with back therapy. And on discharge, she had DP pulses and posterior tibial pulses. And the TCPO2 was not made because of the COVID issue. So this is a peak of 1 month post-intervention, and she achieved complete wound healing 3 months post-intervention. So from my point of view, what are the key points for complex BTK and BDA cases? I would say that you definitely need to understand the anatomy and the anatomical variants of the arteries of the foot. You need to have a meticulous technique with appropriate devices, and you definitely need to be familiar with bailout maneuvers, because without mastering these maneuvers, you won't be able to overcome this 20–30% failure rate related to a standard antegrade approach. And this is described on the body of the literature. And if you sum up these 20% guys who are declared non-option guys on the initial assessment, this is a heavy weight on your shoulders to start with. And for these no-option patients, there's still a last hope, as Lorenzo has mentioned, but which is venous arterialization. But this maneuver should just be reserved for real no-option guys. So what we basically do is to direct connect flow with arterial flow with the veins, and it refills the capillary, which are filled retrogradely. We increase flow in hibernated vessels, increase tissue nutrition with an increase of PO2, and there's also an angiogenesis effect. So this is a case of venous arterialization. It's a 77-year-old male, no allergy, high blood pressure, diabetes mellitus, dyslipidemia, chronic kidney disease, which is quite typical for these sad guys, with multiple prior failed revascularization attempts. So he came to our ER with a complete necrosis, retonecrosis, and also, as you can see, an ulcer on the previous transmetatarsal amputation. And this guy was offered a BTK amputation in another center. So on clinical examination, he had no pulses below the knee. White blood cells were not really raised, non-compressible ABI, and a really low TCPO2. So this is the angio, and as you can see, there's quite calcium there, no actually BTK vessels, and at the level of the foot, nothing at all, what we call a desert foot. So we gain venous access at the level of the plantar vein, echo-guided. So we progress O18 wire, which runs parallel to the calcified artery. It's on the posterior tibial vein. Then we place a 4-French sheath to assure the access. And then we look for the takeoff of the posterior tibial artery, which is going to be the spot of the connection. So we perform a simultaneous phleboangiogram to check for the best spot for the communication. And then we progress from the venous axis, a snare, and we progress a second snare from the arterial axis, parallel to the former one. And then we perform a percutaneous puncture with a 21 gauge needle that's going to be seen easily on the lateral view. And then we will progress an O14 wire. This is the lateral view, and you see the needle is crossing through both the snares. Then we will retrieve the needle, close and retrieve the venous snare. We also withdraw the arterial snare, and through this through wire, we will progress a balloon to perform the communication. This is a sort of homemade method to perform an arterialization. So you can see the communication is already performed, no leakage at all. And then we secure the axis with a balloon expandable cover stent to focalize the flow towards the foot. Then we flare the venous segment, the 5 mm balloon angioplasty. We prep the vein to have some room to place our cover stent. And then we extend our cover stent up to the level of the heel. So at that stage, we just need to gain the plantar arch, the venous plantar arch, and we just loop our wire. Here we are, and we're going to place the wire on the medial marginal vein. And in order to deal with the residual valves at the level of the plantar artery, we perform a balloon angioplasty. And in case of residual valve stenosis, we use a cutting balloon, which is a balloon with the blades. And we retrieve it in sort of a surgical way. And this is the completion angio with flow all over the graft tract and on the lateral plantar and the plantar arch. So the clinical course of the patient was fine. We definitely needed to face what we call the storm post-DVA, because this is absolutely different compared with an arterial procedure. So you need to face swelling, cyanosis, pain, and distal necrosis, which is related to Still syndrome from the artery. Definitely a multidisciplinary wound care is needed, as mentioned by Lorenzo. And this guy had a flow focalization with coils 1 month following the procedure in order to focalize flow to the foot. And he was discharged 4 weeks following the procedure with posterior tibial pulse and with an increased TCPO2 of 40 millimeters of mercury. So 8 weeks following the DVA, and this is an essential to wait for this period of time to leave time to the venous system to arterialize, we perform a Lisfranc amputation. This is the picture 2 weeks later. There's some wound issues, and that's probably related because this was one of our first cases and we didn't follow the policy of the tension-free amputation, which is really relevant. But we managed to deal with the wound with some debridements, and eventually we achieved complete wound healing 5 months following the Lisfranc amputation. So what is the recipe for success? This is well known by Lorenzo. So you need to carefully plan your procedure. You definitely need to be skilled and have a lot of patience and never ever give up. So thank you very much, guys, for your attention. If you have any query, feel free to contact me in my email account or social media accounts. Thank you very much.
I think it was fantastic, August, and I think, you know, very few people in the world can do the stuff that you do. Also because, you know, this very humble guy came out with this kind of solution, technically speaking, with the 2 snares, where actually let's say the standard procedure is far more costly because there's a company who provides all the kit, and actually it's very expensive. And August actually is very, I think it will be remembered for years and years and years for this kind of approach, because it permits also to centers which don't have the budget to do the procedure with this kind of material, to do it in a sort of actually quite easy, but a very, very, very effective way. So it's just to have the right idea at the right time. And August is a specialist in finding the right idea at the right time. So I have some questions which are coming from the audience. Actually, there's Erica who asked what causes calcification in artery? And I heard that Dr. Isa mentioned that in his presentation. So could you just give us an answer?
Well, we've seen actually that the pattern on these vessels, VDK vessels, is not the standard atherosclerotic pattern. And as you mentioned, we have seen that there's a specific pattern, which is a medial artery calcification, which has to do with the macrophages at the level of the tissue of the medial, which sort of produces bone itself. So it's quite, sounds odd, but that's what we see. And this is a quite important issue because we have to deal with these sort of vessels, which are really difficult to manage compared with the standard atherosclerotic vessels.
Very good. And especially, yeah, diabetic patient and dialysis patient, as you mentioned before, are the worst because they add this kind of calcification from 2 different sources. So, and another good question is, do you do all your procedure under general anesthesia?
No, not really. So we try to start with some local, and I know you are not really keen on sedation, but low level sedation. And if we are thinking about complex procedures, definitely we need to go for even a general or a nerve block.
Okay, it's good because I mean we, as we said also during you said during the presentation, most of the patients, this is not a painful procedure itself. It's just sometimes the time that you're spending recanalizing. It's not so. It's always 10 minutes. So yesterday I just finished 4 hours intervention. You know, and I'm sure that everyone who's usually dealing with this kind of difficult procedure are not spending like half an hour every case. So it's very good. And also, if you're skilled, it's even better. But if you're not skilled, you don't even have the time in an entire day to do all of this kind of stuff. So I thank you a lot, August. Now.